All right, so I'm going to start with explaining the sampling methods. So researchers use selective sampling to select the sample from the population. Selective sampling allowed the researchers to choose the participants from a specific group of people in a specific location. In this case, it was Northern California, and the group were adolescents in foster care. So this is done because the researchers are looking for results and information related to healthcare disparities among adolescents in foster care. So the participants consisted of adolescents who were assigned a CASA advocate from the courts, and CASA stands for Court-Appointed Special Advocates in 3 Northern California counties. So children who did not speak English and those who had a form of cognitive impairment or thought disorder were excluded. There were 136 total participants in the sample. So this particular group of participants actually faced a lot of vulnerabilities. For one, they were all in foster care, and while there was no specific numbers given, I think we can assume that a lot of them didn't have permanent foster care placement. There was also no specific information given on their exposure to the juvenile justice system. However, they were given a CASA volunteer who is normally involved with children who are facing some disparities at home in the foster care system, or they are working with social services in order to get a permanent placement. A lot of the participants were also part of racial minorities, so actually the majority of the participants were from racial minorities, with 65 of them being African American, 19 Latinos, and 30 who identify as more than one race. The others, which is about 22 people, identified as white or Asian. So they did have restricted access to healthcare essentials, and the population had an increased participation in risky behaviors. So the study collected information on the sample's age, their ethnicity or racial identification, gender, age of entry into foster care, reasons for transition into foster care, length of time in foster care, and the number of placements. The Child Health and Illness Profile Adolescent Edition, which is going to be referred to as the CHIP-AE, was also employed to examine 6 domains of healthcare, which also included several subdomains. The instrument was a self-report tool that measured the sample satisfaction with the healthcare they were receiving. The researchers used 4 domains to generate 13 health profiles. The domains included satisfaction with health, risks, resilience, and discomfort. These items were chosen because the researchers believed they could be altered with clinical intervention. And this was a longitudinal study. The dependent variables were the 4 subgroups for healthcare status, so they included the satisfaction with health, risk levels, resilience levels, and discomfort levels. The independent variables were the current age of the participants, age of first foster care placement, length of time in foster care, and gender, although we don't see too much with gender throughout the rest of the article. Satisfaction with healthcare or healthcare status, as I listed it on the PowerPoint, was measured first using ordinal scales of measurement to determine the participation's actual level of satisfaction with each domain, and then it was used on an interval throughout the rest of the article. Age was also included, which age of entry into foster care, which was also on interval, and gender is nominal. The CHIP-AE was used to measure the ordinal and interval data for health status. The data was collected through self-report. The CASA volunteer met with an advanced practice nurse once a month to discuss the health needs and concerns of the adolescents they were assigned to represent. So the adolescents were able to discuss what they viewed their healthcare needs were with their CASA worker. There were a lot of significant major findings with the study. So out of the 136 participants selected for the sample, only 131 were able to complete the study. The mean age of the participants was 14.8 years old. The mean age of entry into foster care placement was 8.02 years old. Participants reported several reasons for their entry into foster care, to include parental neglect and abandonment, parental substance abuse, physical abuse and emotional abuse by the parents, parental incarceration, mental illness. There were also some child-related reasons, to include aggressive behavior, runaways, sexual risk-taking, and problems getting along with others. The mean amount of time spent in foster care was 6.32 years. There was no statistical significance among satisfaction with health care and age of entry into foster care, along with the length of time in foster care. The significance occurred at current age and satisfaction with health care. So adolescents 14 years of age but less than 15 years old reported having best health status and fair health status. So the mean age of adolescents reporting poor health status was 16.36 years old. The results indicated that the participants in early adolescence reported higher rates of satisfaction than those in middle adolescents who reported poor satisfaction rates. The data was analyzed using a one-way ANOVA test for variance. The analysis examined the relationships between age of entry into foster care, length of time in foster care, and current age against satisfaction with health care. The researchers were looking for differences among the means for each variable that was tested. The data was presented in detail as part of the text of the article. There were several tables included as appendices to the article, but not included among the text. The ANOVA output and a chi-square was also included in the appendix. Comparisons between the variables were presented in charts that displayed the frequency, which would be the mode of the responses about healthcare satisfaction, and what percentage it represented of the sample. A chart was presented for each variable they compiled into the 4 groups that the CHIP-AE was testing for. The descriptive statistics that were presented in the text of the article were the means, standard deviations, and then the tables presented the modes. The research question was, are there subgroups of adolescents within the sample who have particular health vulnerabilities based on profiles of health dimensions? The answer to that question would be yes. The study showed that current age of adolescents in foster care had the most impact on satisfaction with health care. This domain was the only subgroup to present a statistical significance of satisfaction with health care. There was no significance in age of entry into foster care and the length of time in foster care on perceptions of health care. Thus, the vulnerability exists in older subgroups of adolescents in foster care who reported having poor health. More girls also reported having poor health than boys in the sample. The one-way ANOVA was used to compare differences among health status rankings in demographic, which would be the current age, and foster care variables, which include age of first placement and length of time in foster care. The ANOVA found that there was a difference in health care status and current age. The results are difficult to generalize to all adolescents in foster care because this particular sample were assigned CASA workers to assist in getting responses. The researchers state that CASA volunteers are usually assigned to children with complex layers of issues. Thus, the results may be biased towards them and cannot be generalized to healthier groups. The results also may not be a representation of those who were placed in more permanent foster care homes or those in non-urban areas. There was also no group of comparison. The CHIP-AE also relies exclusively on adolescent self-report and does not obtain insight from foster parents, healthcare professionals, teachers, and anyone else who may be in a caretaker position for a child that is in foster care. For future implications and conclusions, the study presented the importance of positive reinforcement among adolescents in foster care. It is important to reinforce their perceived strengths and promote positive self-esteem. It also stressed the importance of early intervention for the teens who reported poor health status. Early intervention can prevent them from worsening health statuses and reduce risk-taking behavior. The study also suggests that developmental age and gender may also influence health profiles. The study essentially identified that stages at which children need the most health profile intervention. The results and conclusions affect adolescents in foster care primarily. It also has significant effects on foster parents and other care professionals of facilities, as well as healthcare professionals involved with children in foster care. The study also affects CASA workers, as it may increase a need for them to be appointed for more adolescents in foster care in order to have them have a larger voice in matters that concern them and not just in health profiles. The conclusion recommended that researchers should also survey adults who were entrusted by the adolescents to get a more reliable depiction of their strengths and weaknesses and to get a more accurate depiction of their health profile. They also recommend separating higher risk adolescents from lower risk youth in order to determine what specific resources are needed to increase the health profiles of the higher risk youth. And here is the reference page.